All right, everyone, thank you for coming to today's webinar, Implementing State and Local Overdose Prevention Policies in Your Community, presented by the Network for Public Health Law and Change Lab Solutions. Today, this will be recorded, and we encourage everyone to please use the Q&A function at the bottom. We will be monitoring the chat, but just for the ease of the speakers and presenters and with the time that we have today, it'd be great if you could put things into the Q&A function. But with that, I'll hand it off to Amy Lieberman, who is our Deputy Director of the Harm Reduction Legal Project here at the network, to introduce the speakers and the rest of the presentation. So Amy, over to you.
Thanks, Daniel. Hi, everyone, and welcome to Implementing State and Local Overdose Prevention Policies in Your Community. My name is Amy Judd Lieberman, and I'm the Deputy Director for the Network for Public Health Law's Harm Reduction Legal Project. We work to address legal and policy barriers that impede the establishment and expansion of evidence-based harm reduction measures. We want to acknowledge that this training was supported by the Centers for Disease Control and Prevention as part of a financial assistance award with 100% funded by CDC. And the contents of these are the authors and do not necessarily represent the official views of or an endorsement by CDC, HHS, or the US government. I'm pleased to now, I'm going to be talking to you with a partner of mine from Change Lab Solutions, who's going to give us a little bit of background on the project. And then I'll come back and discuss a little bit more before introducing our speakers for the day. Take it away, Liz.
Thank you so much, Amy. Thank you all so much for being with us today. We're really grateful that you've joined us for this conversation. My name is Liz Olson, and I am a Senior Policy Analyst with Change Lab Solutions. For those who may not know us, Change Lab is a nonpartisan, nonprofit organization that uses the tools of law and policy to advance health equity. We partner with communities across the nation to improve health and opportunity by changing harmful laws, policies, and systems. Our interdisciplinary team works with community organizations, governments, and local institutions to design and implement equitable and practical policy solutions to complex health challenges. So today, we are excited to introduce two new resources that we've developed with support from the CDC and in partnership with the Network for Public Health Law. They highlight state and local policy strategies to reduce overdose and other drug-related harms. So the policy guide pictured on the left of this slide highlights a range of state and local policy strategies, outlining the details of potential options for new policy or changes to existing policy to help mitigate the overdose crisis. And the implementation resource pictured on the right offers guidance on the policy process, supporting readers to put those strategies into practice on the ground. So the policy guide is sort of the what, and the implementation resource is intended to help folks think through the how. They're both now available on the Change Lab Solutions website, and I will drop that link in the chat in a moment. So in addition to these, if you could go to the next slide, Amy, that would be great. Perfect. Thank you. Another resource was developed by our partners at the National Association of Counties, NACO, for this project. It highlights 5 counties using opioid settlement funds to advance health equity, detailing the steps that they've taken in the early years of payments and highlighting some considerations for other localities. That resource is available on NACO's Opioid Solutions Center website, which offers many other valuable resources to support local leaders in their prevention and crisis response work. So I'll share that link in the chat as well in a moment. So just to share some context for how the policy guide and implementation resource were developed, I'll share that our team used a couple of different methods to identify the strategies that we outline in the documents, including an initial scan of peer-reviewed and gray literature to identify existing overdose prevention policies implemented in 4 focus sectors, which are healthcare, criminal legal, schools, and community. Interviews with 22 experts across those sectors who work in a variety of state and local contexts across the nation, including as researchers, healthcare providers, policymakers, community-based organization and government agency staff, policy experts, and advocates. Many also shared their perspectives as people with lived experience. And we're extremely grateful to each of them for sharing their expertise with us. Their insights are really foundational to these materials, and you'll hear some of their quotes today in Amy's presentation. We also conducted an assessment to screen policies across a range of impact and feasibility criteria like strength of evidence, ability to advance equity, which helped us to produce kind of the final group of strategies that are highlighted in the guide. So the policy guide introduces each strategy, briefly reviews relevant evidence and considerations for how the policy can be designed to reach people facing elevated risk, and highlights an example in action at the state or local level. And the implementation resource on the next slide is intended for readers who may be less familiar with the policymaking process. It outlines key steps to put policies into practice, sharing guidance for identifying needed interventions, advancing them through the adoption process, and implementing them so they create meaningful change in people's lives. And our guests today have very generously joined us to talk about their experience working to implement harm reduction approaches in their community. We're so excited to learn from them about the successes and challenges in their work. So I'll just end by noting that this conversation is the first of a 4-part webinar series, each focused on the 4 sectors that I mentioned we focus on in the resources. So today we'll focus on policies that can be implemented in community settings. And for the purposes of this project, we considered those to be settings outside of healthcare, criminal legal, and schools. So housing, public health, and other social services settings. Community-based interventions are often delivered by community-based organizations and community members themselves who are doing really vital work to support people who use drugs, to meet their basic needs and keep each other safe. So we really hope that this conversation and the materials will be useful to you in your work, and we're really excited to engage in conversation with all of you. So thank you again for being here. And with that, I'll turn it back over to Amy.
Thank you, Liz. I wanted to first just talk briefly about some of the main themes that came out of the key informant interviews, because I believe these themes should really be informing policymaking and implementation decisions. And they're things that popped up across all of the interviewees as important areas of focus. And I've included some quotes on the slides to connect the ideas with reality. So first theme was that law and policy changes are critical to making progress in overdose prevention. The need for structural change. Overdose prevention and drug-related harm prevention can't be sustainably plucked out of other needed structural change. It's not, everything else needs to change as well. The quote here saying, so many of the things that we're dealing with are the results of or exacerbated by wealth inequality. Navigating the harm that poverty has on the people we're trying to serve and keep safe is impossible. Another theme was that existing law and policy may pose a barrier to overdose prevention. At the end of the day, the war on drugs is a war on people. We need to end the criminalization of the person. And while drug use is criminalized, that criminalization looms over all policy choices. The ways in which we criminalize people who use drugs act as a disincentive for them to be able to get treatment and ensnares them in the criminal legal system, which just makes it harder for them to get well and more likely for them to die from overdose. And you see this in healthcare policies and decisions as well, right? Healthcare needs to be evidence-based. And here we have a quote from someone saying they can't forget the case of a woman who was pregnant and didn't want to try medication treatment because she knew that it would lead to a child welfare filing at delivery. And she overdosed and both she and the baby died. Another theme is that we need to support both those in recovery and those currently using drugs. Those are distinct needs. Total abstinence is not the only way to reduce overdose, and it's often an insurmountable hurdle. And we know that from other countries, this one's specifically about overdose prevention centers, which we're going to hear more about today, that they seem to be effective in terms of reducing unsafe modes of drug use, which reduces harms associated with drug use and reduces overdose rates without any consequent harm to the surrounding community. Again, the war on drugs ruins everything, and it is based in racism. And this contributes directly to death. There's way too many communities in this country where calling 911 is synonymous with calling the cops. And oftentimes that is enough of a deterrent that in the moment of an emergency, people will not call 911, which could contribute to death. Drug overdose can often be best prevented by addressing the social determinants of health. Whether someone uses drugs or not is often informed by the lack of access to other social goods like housing and healthcare. This quote is about thinking about the housing first model, where people are not kicked out of housing because they continue to use. It connects them to services and gives people more opportunities in affordable and safe housing. Lived experience is key. This came out in every single one of our interviews. People who use drugs know what people who use drugs need to be safe better than anyone else, period. And this last one, sustainable and attainable funding is essential for implementing policy solutions, I think is best summed up by this quote. I think one challenge is that funding and grant contracts operate on a very short cycle. So you're constantly sort of chasing your tail if there's not really any sustainability to the program. You're hiring people who don't have a lot of job protection, and you're always at the whims of administration changes. If you think about it, that's not the way we do cancer care. If our oncology model changed every 4 years because of funding, that would be a completely ridiculous way to deliver healthcare. And why should we be doing that for any other healthcare? So some of the example policy strategies for communities that we noted were increasing access to naloxone, syringe services programs, distribution of fentanyl test strip and other drug checking equipment and other drug paraphernalia, community drug checking or safe supply, and overdose prevention centers. There's a wide variety of choices. There's never going to be nothing that you can do to increase harm reduction-based policies in your community. Syringe services programs, I specifically wanted to highlight because they've long been the backbone of overdose prevention in our communities and have over time expanded services to become hubs of prevention and treatment as well. And they can be a safe space for people who use drugs to feel accepted, loved, and understood. A recent study in the Lancet was published that showing that community organizations using government funding are far superior to departments of public health operating the same kind of services. Community organizations reach people better. Constantly, syringe services programs in the community are constantly connecting with people who use drugs. And so they're constantly able to change to provide needed services. But unfortunately, these services, these basic syringe services, are under attack in communities across the country and need backup from public health and government officials making strong policy choices. The resources we've developed encourage policymakers to have a specific focus on consideration of priority populations. While things like overdose prevention centers will likely help people who use drugs across the board, for example, they may be specifically helpful to unhouse people who use drugs. Public drug use is associated with greater risk of interactions with the police, all of which can lead to rushed and unsafe levels of drug use. And OPCs can provide a hygienic indoor space where people who are unhoused can build relationships and get other support to help meet their basic needs. So when we talk about the policy process, the guides identify 5 distinct steps, but those steps are all connected by, at every stage, people who use drugs and community members, other community members should be involved and engaged and not tokenized, but actually really being listened to and leading. Identifying and defining the problem in the community, envisioning a plan for success, reviewing policies and selecting a policy, developing and adopting it, and implementation and evaluation of the policy, which can then help identify and define another problem. So it is kind of a cycle. This guide, the policy implementation guide, is intended to assist those who are interested in changing law and policy by highlighting how jurisdictions can identify and prioritize policies needed to mitigate overdose in their community, highlighting key steps to consider in selecting which strategies to pursue. Policy adoption, what strategies can be employed to move from a proposal, an idea, to an actual policy change. The guide offers information to support strong policy design and help a proposal move through the adoption process. And then, of course, implementation. What practices can help ensure that policy change, once enacted, translates to meaningful outcomes in people's lives? I have a distinct implementation focus in the guide. 4 main ideas in implementation is talking about our key partners, education and outreach, equitable enforcement of the policy, and evaluation. are key partners at the table to design, evaluate, and improve implementation. How will education and outreach be conducted in the community? How will community members learn about the policy and any new services or opportunities it provides? And what training and support for the workforce responsible will the implementation need? How will the policy be enforced? What strategies can help ensure that enforcement actions do not worsen harms to communities of color, people with low incomes, and others most affected by drug-related harm? And how will success be measured? What is it that we want to achieve? And what are we looking for in a successful policy implementation? So with all of that in mind, I'd like to introduce Dennis Baylor and Anna Jean Yolkin from Project Weber Renew in Rhode Island. I'm going to let them introduce themselves a little bit. And talk about some of the great work that they have done and their team has done in Rhode Island in implementing a new and exciting policy. I'm going to stop sharing my screen so that we can see Dennis and AJ. All right. Let's just start with, why don't you give us a brief introduction to yourselves and Project Weber Renew?
Oh, no, please, you go, Dennis.
So, hello, everybody. Thank you for joining us. My name is Dennis Baylor. I am currently the Overdose Prevention Program Director here at Project Weber Renew, but I'm going to have a new title coming up real soon, which is the co-director of the Overdose Prevention Center. Coincidentally, AJ and I are both sitting in the location that we found where the OPC will be run at. We're going through a training right now, working with our partners at On Point in New York, and so we're excited. We're just on it's very short time now. We'll have this location open. But back to me. So I'm a person in long-term recovery. I've been with the organization for almost 10 years here, and I'm just thrilled and pleased to be able to do this work as a working with other individuals as a peer. There's just, for me, there could be no other more satisfying kind of work.
Cool. Thanks, Dennis. So I'm Anna Jane, and most people call me AJ. I'm the Director of Strategy at Project Weber Renew. A 2-sentence background. Project Weber Renew is a community-based organization, a harm reduction and recovery organization based in Rhode Island. So smallest state, biggest harm reduction organization in the smallest state. So we have drop-in centers, we're a syringe service program, we do outreach, peer recovery, case management, HIV testing, and then now opening this overdose prevention center and a bunch of other things I probably didn't mention. We serve around 6,000 individuals per year across 22,000 encounters. And my role, before I worked at Weber Renew, I worked as a volunteer along with many other people to help get the law for overdose prevention centers passed. So Rhode Island was the first state that said that this public health intervention was legal. So I'd be happy to talk more about that. And then now at Weber Renew, my role is really project managing the opening of our overdose prevention center, which we're planning to have open in the fall. So yeah.
Thanks so much. And what you were just saying about volunteering and the movement to get this, to get overdose prevention centers legalized in the state is my next question. Can you discuss like the origins of pursuing this legislative change? What, obviously somebody thought it was a great idea, but like, then how did you decide that this was something that could actually be pursued?
Yeah, absolutely. So clearly the need for this came from the vast number of people in Rhode Island who are dying of overdose, and the very strong evidence that overdose prevention centers are a very clear way to keep people alive. In about 2017, there was a group of people who came together around a table. Our medical society actually helped convene that group, and I give them a lot of credit for really saying this is something that we should pursue at the state level legislatively. And that included people from various different organizations, not only the medical society and medical providers, but recovery organizations, harm reduction organizations, all these different people and legislative leaders who really wanted to take this and make it really champion this issue. And so through that coalition, we worked with lawmakers to craft different iterations. It took 3 years, but to craft different iterations, and then also had a few like dedicated volunteers at the State House who were really consistently talking to lawmakers, not only about overdose prevention centers, but about like ways to address overdose overall. Because what we found was a lot of lawmakers had either direct or indirect sort of experience with overdose. Members of their family, members of their community, and they really saw it as a public health need, but they didn't know the tools necessarily to address overdose. They knew that what we had been doing wasn't working, but they're not experts in everything. They're a part-time legislator. They have to they work on so many different issues, and so having people who could really connect with lawmakers, build those relationships, and help educate lawmakers, I think really helped. And in addition to working within this coalition to move this along and having really strong legislative sponsors. So that's a bit of how that came to be. This was all during it sort of ended up getting passed, I think, during COVID, which I think was also really important because it was a time when we took really different public health approaches to public health crises. And so I think it was a moment when people really saw, okay, we can do things differently. Let's take a leap of faith and let's pass this program, which it was framed as a pilot program. Let's try this approach to try to save lives.
Yeah, that's fantastic. And yeah, it sort of is a confluence of events, right? That maybe that people's minds were open to trying new things because obviously of the overwhelming death and epidemic of drug-related harm, but because of the COVID situation as well, we're seeing new strategies. Did you have any specific strategies in terms of approaching community members? And it sounds like you maybe had some strategies to approach decision makers by like giving them the information. They're like, we want to do something, but we don't know what to do, and we're there for that. But how did you get the community to also support these kinds of changes?
No, I could say, so our organization was built basically on street outreach. The organization was built by engaging with individuals, whether it be people who use, business owners, to teach them about Narcan and overdose prevention, how to recognize overdoses. We are a part of the community. The majority of our staff lives in the community. So through that engagement, and through, of course, in this urban area, our community members, business owners, they see the public usage, they saw the public overdoses, the paraphernalia, because we're a small state, like AJ had alluded to. You can't. It's hard to not see how the drug use that leads to overdose is devastating our community, devastating families. So again, just through that engagement, through conversation, we were able to connect with a lot of people who are on board, and even those who are on the fence realized, I think that's something else needed to be attempted. Just too many overdose deaths, too much public use in the urban area. So I think that we were fortunate. Again, the timing is everything. With the timing with COVID, with the onset of fentanyl, xylazine, something different had to be attempted. And I think we did a pretty good job of highlighting both quantitative and qualitative data to show that this is something that we should try. And again, it's a pilot program, so we had the benefit of pitching it as a pilot. It may work, it may not work. We inside know that it will, but for the community, it's like, this may be successful. If it's not successful, it won't continue. So people were willing to give it a try, and we're very, again, because we're so ingrained in the community and so connected, we were able to make those connections and get this started to give at least give it an attempt.
Yeah, that I feel like that trust that you already had among the community would put you in this like great position to be able to take this bigger, bolder leap.
Absolutely.
And I think that's, you know, that's sort of what the whole community, this whole community sector is about, right? Is that a lot of these policies need to come from community-based organizations that already have this kind of rapport. Speaking of community, how did you center and give voice to people who use drugs in the process of getting this policy adopted, in the implementation, any part?
No, I'll take that. The majority of our staff who are out there providing services, basic needs, life-saving Narcan, fentanyl test strips, we are peers. We are people who I've experienced the challenges of using drugs in public and being unhoused. And yes, I am in recovery, and I've managed to make some changes in my life that I consider a positive, but it's a process to get there. And that process goes nowhere when people die. So being a peer, the peer voice is so important. It's nice to have the backing of the medical establishment and the lawmakers, but that peer voice, when utilized in sincerity and honesty and with some passion, goes a long way. And I share my own experiences. I share how I understand the experiences of other people who are using, and especially the ones who, aren't housed right, and just their voices aren't heard. So we as peers are able to be a conduit for that voice and just say, we don't want to die because of the usage, whether it's substance use disorder or whether it's an occasional non-chaotic use. All those people are dying. So just expressing that, I think, goes a long way. And it's something that we had to keep saying over and over and over again. But I think ultimately, they heard us, and again, got on board to give this a shot.
And I think now that we're in the implementation stage, that's really, I feel like there's so many design questions, implementation questions, there's so many details, and that lived and living perspective is so important. Not to say, okay, our overdose prevention center is good or bad, do they save lives or do they not, but exactly how are they going to save lives? What services are going to be offered? How will staff interact with clients? Just so many details that I think it's not just okay, the law's done, hands up, there's so many more important questions where, yeah, that professional and personal experience is critical.
I had the great pleasure of hearing both of you speak about this before, and interacting with you on this topic. So I know specifically, Dennis, if you wouldn't mind sharing about in the regulatory process, the story about that you've shared with me before about how people who were making these regulations maybe didn't really understand what was actually going on in the community, especially in the Black community, and how you were able to center their voice in that process.
Yeah. Here in Rhode Island, of course, fentanyl has found its way into the entire drug supply. At the time when I was on the regulatory committee, we were hearing that Black and brown people were dying at a higher rate than the white community, the white drug users. Primarily, those people were stimulant users. people who were doing powder cocaine, crack cocaine, methamphetamine. That's mostly centered in our Black and brown communities. During the regulatory process, we're trying to put in place regulations, policies, and procedures that would not be a barrier for a small organization to open up the Overdose Prevention Center. In order to get it implemented as quickly and simply as possible, it made sense to some people that let's just make it for injection use. Getting into the conversation about smoking indoors and ventilation and all those things seemed like too much of an economic burden to put it in the regulation. Well, of course, I'm a Black man whose primarily drug of choice was cocaine, powder, and crack, and I had to highlight the fact that in our community, the deaths were affecting the Black and brown community at a higher rate. So how could they possibly implement a program that doesn't provide services for that community? This is historically how our society handles issues along those racial lines. It's easier to get it done simply than to really do it correctly by engaging with everyone who's having those challenges and, of course, experiencing the deaths, you know, again, destroying families and communities and so on. So myself and at least one other person on the regulatory committee stood up and said, no, there's no way we can implement this program without having safe inhalation as a requirement of the regulation. Fortunately, they heard our voices. Again, peer voices are important, need to be heard. And as a result, of course, the regulation now has in there that if you want to open up an overdose prevention center in Rhode Island, you must have inhalation services as part of the program. But you know, we all know the story about the racism and colonialism and how people of color, I can tell you, don't often feel like the systems are set up for them. Well, this is a step in the right direction to show that everyone deserves to be treated with dignity. Everyone should be allowed to have some hope. And through those combined efforts, we know that we're going to save lives, we're going to engage with the community that we haven't often engaged with previously. And also data shows that people who come to these programs are 30% more likely to get into recovery. So if that's the path that they want, we know that we provide a stronger chance of that occurring.
That's such an incredible win, especially in the current climate where, you know, there's all this rhetoric coming from certain aspects of our society that, you know, handing out crack pipes is like such an issue, but they're missing the picture that people are going to continue smoking drugs and that they're going to continue dying unless you offer services to everyone.
Yeah, and again, I want to highlight the timing of everything. Because of COVID, we didn't want people sharing the pipes. So able to get Department of Health and those other state organizations to realize that in order to eliminate the spread of, to help reduce the spread of COVID in the drug using community, we have to provide safer smoking supplies. So again, the timing of everything just happened to work out right for us. And to me, that also just is a indicator of how this is the right thing to do. It's just the right thing to do for Rhode Island, and hopefully be a roadmap for other states to follow. Granted, we have it pretty easy here. I know the stories of other states. Some states can't have Narcan, no safe syringe exchange. That's tough, and it's going to take time. But those voices that we have here, they continue speaking about drug user health, continue to highlight again the devastation of these deaths in our country. I'm sorry, I'm starting to run on a little bit, but I do a lot of presentations and Narcan trainings, and in case those of you who don't, in case you don't know, the #1 cause of death in our nation for individuals between the ages of 18 and 45 is accidental drug overdose. #1 cause of death for that age range. We need to do something, and those voices need to be heard in those states where syringe exchange is not allowed. We just need to keep highlighting that saving lives is #1. Recovery is a hope. We hope maybe they'll get in recovery. Hopefully they will. But #1, we need to do to save lives.
Yeah, it's thank you so much for saying that, Dennis. You're not running on. There's so many wins in this process. Is there anything, could you discuss, was there any specific roadblocks that you faced during this implementation process, like something that was a stumbling area?
I think that there were a few. I mean, there wasn't, I think that initially when we wanted to have this conversation, especially with members of the state government, there were a lot of people who were like, we can't even have this conversation because of the federal law. We can't have this conversation because of the federal law. And it took a lot of, Rhode Island's a small state, so a lot of like sort of peer pressure because, everyone kind of knows each other in Rhode Island. I think we use that to our advantage to kind of get around some of the people who are like, you can't talk about this because it's federally illegal. I think one of the largest challenges for implementation has really been finding a location. So we were really very thoughtful and intentional about where we wanted to be. We wanted to be in a place with public transit. We wanted to be in certain areas of the city. We wanted to be, we needed to, within Rhode Island, we wanted to be in Providence. Providence is a very small city. The commercial real estate market is very wild right now, as is the housing real estate market. We wanted to be in a less residential area, et cetera, et cetera, et cetera. We wanted to be in a place where there was overdose activity. And so I think that was really one of our biggest challenges, was just, it took a lot of time to find a location. And I think we're all really feeling the pressure of time and wanting to open as quickly as possible. But we knew that without the right location, we really would not be able to open.
If I could add to that.
Yeah.
Again, timing is everything. At the same time when we were completing the regulatory process, Rhode Island received its opioid settlement dollars. So there we go. One of the other challenges would have been, or even is still, the economic side of it. Well, we were able to, of course, I'm on various committees, and I was on another committee that had to do with the opioid settlement dollars. And we had gotten a chunk of that money set aside for harm reduction and for the implementation of an overdose prevention center. So again, with the timing of the settlement dollars coming in, that of course helped. But as a nonprofit, and those of you who work in the nonprofit world, funding is a challenge, will always be a challenge until we get the system to change, as stated on one of those slides about how they care for people who have cancer. Until we make those type of changes to the system, we're still going to have that challenge of keeping things financed, keeping the organizations open, keeping the staff paid. So that again, that was a challenge, but with the timing of the dollars coming in, that certainly worked in our favor as well.
Yeah, thank you. Thank you for that. I want to give some time for people in the audience to ask questions, but just for my last question, is there one thing, one tip, or one idea that you would share with the participants on this webinar that you found to be like crucial to your achievement in this policy's implementation? I'm sure there's a million things that were crucial, but if there's any like one like nugget of wisdom you could impart.
Again, there are many things that come to mind, but I think for me, it's about the lives that we've lost. It's sad. And people need to feel that. People need to feel what the families feel, what the friends feel. That loss, there's no denying it, there's no getting over it. We just need to express that the value of a human life is worth us going to what is now considered extreme measures. We don't want this to always be an extreme measure. This should be the norm, but the value of a human life, as we see with other health issues, there really shouldn't be any no holds barred. We do what we need to do. We should do what we need to do to try to save lives. Again, the number one cause of death for people from 18 to 44, the number one cause of death. What can we do to bring down these numbers? We just need to keep the squeaky wheel, keep saying it over and over and over again, highlighting, again, there's plenty of data, plenty of qualitative data out there. There's quantitative data out there. We just got to keep raising our voices. We need to get together with the peers, the medical professionals, the legislators who are on board, and just keep spreading the word about we need to save lives and how we're going to do it.
Yeah, I think, I mean, obviously everything Dennis said, I think in addition that this all comes from relationships, right? Like this policy work all comes from relationships. It comes from relationships with people who are directly impacted. It comes from relationships with organizations. It comes from relationships with lawmakers, and it's all done in community. And I think sometimes people miss that, like, just like, oh, I'm going to go in and do all these things and just plop down this research or plop down this law. And it's like, it's all very relational, and like, that's how things happen, sometimes for better, sometimes for worse. And I think just always centering not the humanity and the relationships in the process is important.
Thank you so much. I want to encourage people to put questions in the Q&A. Or raise your hand if you, I don't know, Daniel, I don't know if you can actually see people with raised hands, but I see 2 questions in the Q&A already. So I'll start with, it sounds like one of the reasons behind initially leaving safe inhalation services out of the regulation was a concern that small orgs would not be able to build them appropriately. How was that aspect addressed? Is there additional funding for ventilation upgrades to buildings, for example, or did it turn out that the concern was outsized?
I think the concern was outsized. We have cigar rooms in our state. People can smoke their cigars. We have hookah locations. People can smoke in there. So there are locations in our state that aren't really tremendously regulated where smoking is allowed. So I make it such a big deal when it comes to drug users. That's just our society doing what it does, taking drug use and turning it into a bigger deal than what it needs to be. But again, we were fortunate with the opioid settlement dollars. Small organizations like ours were able to apply for those funds, utilize those funds to get that design into our build out. But yeah, one of the people on the regulatory committee referred to it as economic racism. We don't want to engage in economic racism. We want everybody to be able to utilize and get benefits of these services.
And I also, and this is a question for you, Dennis, didn't in the regulations, they also made them less strict around the inhalation to try to make it more accessible to community organizations too? Can you
Exactly.
speak to that?
Yeah.
Yeah.
I can't think of the term, but it's getting all the molecules out of the air to ensure that no bystanders have to be exposed to the crack cocaine smoke. You were able to get those demands lowered, and simple, strong fan ventilation is always required to clear a room. But yeah, as with anything that's important, it took time, it took conversation, it took that engagement. And we were able to get a regulation in place that satisfies the health department and also satisfies a small organization to be able to implement it.
Thank you. I have another question here about, we talked about talking to the policymakers and to the community, but what was your experience approaching relationships with the media to generate positive responses, hopefully, from the community?
Let me take that. Yeah, I think that our relationship with the media has been pretty positive. I think that, again, we've been working on this for so long. I think that also helps is that, we first started talking about this law in 2017, 2018. And so it's not like a coming out of nowhere narrative in the media. And we have strong relationships with people in the media. I think, again, people in the media saw the need for, that this is a crisis for all the, data that Dennis cited, and sort of has had interest in it. And I think just ensuring that when people and staff are talking to the media, that they're well informed about what's going on, and also, again, sort of centering people's humanity, and also citing the really strong evidence that exists for these interventions. And so I feel like we've had a pretty positive experience with the media. I think even when the law was being passed, there was no like boogeymen who came out of the woodwork. And so again, I think that is in part because people really, like, on a fundamental level, see that there's a need to do something, and to do something different.
Thank you. I'm gonna ask another question. Do you have any advice for supporting an individual using substances in a shared living environment? Drug use does not disqualify an individual from housing within our agency. However, they cannot be used on the premises due to safety concerns for children and funding issues. This is coming from a nonprofit domestic violence provider. I'm not sure if that's something that you have any ideas on. Basically, like, how do you support an OPC type of environment, but in a shared living environment? It's okay to not have an answer.
It's challenging, to say the least. Shared living environments and substance use, of course, safety has to always be the #1 priority. Whether it's some type of monitor in a safe space, electronic monitor in a safe space, or some type of phone line to keep an individual safe. Definitely a challenging situation, and yes, a hard question for me to answer. There are going to be different philosophies on whether that even should be allowed, but as we know, people who use are going to use. The best thing that we can do is try to put procedures and policies in place that can help keep them and their families safe. But again, I certainly don't have the best answer to provide. But keeping people safe should be the #1 priority. And people who are going to use are going to use. And if you're going to force them out into the street, you put them at a higher risk of overdose and overdose death. So yeah, we need to find ways to, even in that shared living environment, we need to find ways to keep people safe.
Thank you. I'm gonna ask this question next. If I don't answer your question, by the end of this, I'd like to I'm gonna put my email address in the chat. So hopefully you can follow up if I don't get to your question today. This question is, often when it comes to harm reduction, as you said, with the hookah and cigar lounges, I often see parallels between things in harm reduction and the prohibition area. As bars are quite simply an alcohol safe use site and bartenders being harm reductionists that can cut you off, it shows a unique form of cognitive dissonance in our Western drug culture. Have you found this to be a useful analogy to explain harm reduction to community members, or are there other steps you've needed to address to tackle this cognitive dissonance between a dangerous but regulated substance like alcohol with the crisis of today?
Complex question in my tired mind. That was a great analogy that the individual put in there themselves, but yeah, harm reduction. I've heard it stated in different ways. You know, the stop sign, the seat belt, the motorcycle helmet. We as human beings, we engage in risky behaviors, whether it be for pleasure or recreation. You know, we engage in risky behavior. In any of those activities, there are things in place, best practices to help keep a person safe and, of course, prevent them from dying. Harm reduction when it comes to substance use has to be viewed along the same lines. Yes, it's a risky behavior. So what can we put in place as a country, as a society? What can we put in place to help keep those people safe and keep them alive? It's very simple, but it goes back to the criminalization of use that makes it so complex. There are those of us, of course, you know, fighting for that whole criminalization piece. But until we achieve that, we need to look at the harm reduction, how we keep people safe, even if they engage in risky behaviors. And yeah, pretty simple.
I'm going to try to combine two questions, although I'm going to begin it with a caveat. I know you said that Rhode Island is a unique case because you're so small, and that this is not necessarily the jurisdiction that you were working in. But what advice do you have for working within tough on crime jurisdictions that are heavily opposed to the suggestion of an OPC? And also, adding another part of the question, is there a type of evidence that you found most persuasive with policymakers, like stories versus statistics?
Yeah, I'll take the second part and then I'll take the first part. So I think my experience, I can only speak from my experience, I can only speak from working in Rhode Island, is that lawmakers like less is more in terms of information. So sometimes people come to lawmakers, they have a whole peer-reviewed journal with a great data model and all the statistics. Like, lawmakers do not care. I'm sorry to all the researchers out there. They want to know, like, big number, what's happening in their community. That's it. What can they do? And so I think that half a page of bullet points tops, maybe like 3 bullet points. So I think it's like one of those things, less is more. They have a lot going on. They have to work with a lot of details and a lot of different topics. And so I do think stories are really, really important in that. Again, those personal relationships with people, you know, especially for folks who do have lived experience, people who have been overdose survivors, I think those really resonate with lawmakers. And I think that I do think that the statistic around that, no one has ever died of an overdose of an overdose prevention center, like that statistic is just like, that's it. You don't need all the other statistics. Like, people can really understand that. I mean, again, I do think I can't speak for working in a state that really criminalizes harm reduction services. Again, that's like our caveat. I think in Rhode Island was one of the first states to like have needle exchange, to decriminalize the possession of a syringe in the early 90s. And I really have a lot of like gratitude and respect for activists, especially like HIV/AIDS activists who really worked hard on that 30 years ago but I'd say that again, pulling from people's lived experience and their personal connections. And I think just like really leaning into the idea that like what we have been doing has not working, that like has not been working, like putting people in prisons has not been working, arresting people has not been working, and using that as an entry point. I also know that like, I think that sometimes the framing of like this can keep the whole community safer. I think it can work. It can be a little bit of a double-edged sword, but like when there's less hepatitis C in the community, it keeps everyone safer. For example, like if there's a needle stick or something in the hospital, it's just like all these things that it's about everyone, not just people who use drugs. I think again can sometimes be an effective strategy to bring people in. And I think another thing we found that was really effective was we did not like align ourselves with other we did not align ourselves with political parties. We did not align ourselves with other causes, even if we know that this work is very intersectional. And so like, obviously this work intersects with housing and intersects with reproductive justice, et cetera, all these things we know. But in terms of talking with lawmakers, we were nonpartisan. We were not affiliated with any other groups. And I think that helped us really focus the issue and not get caught into like, there was a big law about abortion happening that year too. We did not sort of get caught up in some of that like very complex political scenarios. And I imagine that in a state that is harsher to harm reduction, that would be like especially important. So those are my thoughts.
Well, go ahead. Man, there's so many other good questions. Let me look. I'm just gonna say, I'm just gonna ask this one last question. Have you had experiences, this is sort of maybe a little bit off of the subject of adoption and implementation, but I think it's very important for ongoing implementation and evaluation. Have you had any experiences with first responders and peer support and compassion fatigue? And if yes, how did you address education efforts with them? Oh, I see. This is specifically about first responders, not necessarily in your organization. Sorry, I misread the question at first. How did you address education efforts with them to understand drug use and harm reduction efforts? So how did you engage in the community, with the medical community, with emergency medical services in your community? And did you find that there were people who are experiencing this compassion fatigue and not really receptive to your advanced?
Well, I'd like to say, as a result of their compassion fatigue, they know they need help.
Mm.
They know that they can't be the only ones to continue to do that work with the people who are overdosing on the street. They need some relief. First responders and law enforcement. I think for our state, they knew that they needed community members to do something to help out. Well, here we are, harm reductionists. We want to help them. We want to take some of that load off of their plate. And of course, the economic impact in the emergency rooms. Yes, the ER nurses, they want some help. Or EMS first responders, they want some help. Law enforcement wants some help. So for us, what the Overdose Prevention Center can do to relieve some of that burden, I think was pretty appealing to them, actually. Yeah, the police are tired of those petty arrests. They're tired of the public usage. They're tired of getting complaints from the neighbors. There's some place where people can go to get out of their jurisdiction to use indoors. Many officers are like, good, get them inside. I don't have to go arrest them anymore. Same thing for EMS. This person has been out here. I just gave this person Narcan 17 times. Wish there's someplace else that they could go. Well, overdose prevention centers relieve that burden, and not only relieves the burden of the responders individually, but from the system and the cost saving. It's an all-around benefit. We think that everyone can and will benefit when we get more of these centers on board throughout the country. Again, it's some burdens can be relieved as a result of life-saving attempts, as a result of giving people dignity, as a result of providing hope. It's a win-win. It's just a win-win.
Thank you so much. I wish that I could address all of the great questions. I have put my email address in the chat if anyone wants to follow up with questions or more information. And I want to thank Daniel and Liz and everyone who's joined us here today, but especially Dennis and AJ. And out of respect for your time, since I know you're doing trainings, getting ready to open your own site, and respect for the time of everyone on here, I would just like to say thank you so much. And I encourage folks to look out for the network will be posting registration links for the upcoming webinars in this series. They'll each focus on a different sector with different speakers. The first 10-15 minutes or so will be the same, but we hope that even if it's not a sector that you're interested in, that maybe you'll come and learn something from one of our other great speakers. Again, thanks, Dennis and AJ. So grateful, and thank you everyone for listening. Daniel, is there anything you need to wrap up with?
Nope. The only thing I'm sorry, the only thing I'm going to point out is that you will be receiving a copy of the slides after I clean them up a little bit from the speakers, as well as a recording will be posted on a specific webpage on the network's website, and you'll be receiving an email when both of those are uploaded. So don't have to worry about that. But other than that, thank you all for your time today and hope you have a great afternoon. Thanks, everyone.